all experience pain at some point, but is eliminating all pain the right thing to do? Dr. Anna Lembke is the author of Drug Dealer MD, a book that explores the many surprising factors that contribute to the current epidemic of opioid abuse in America. In today's episode of the Nutrition Heretic podcast, we'll learn why patients become addicted, how drug companies contribute to the problem, and why doctors have gotten caught up in the system.
We interrupt this program to bring you a special report.
If you're still confused about what to eat and not getting the results you thought you'd get by going organic, go to nutritionheretic.com and download the shit list of 7 health foods to avoid like the plague for free. The shit list details what health food companies want you to believe about the crap they peddle and why the real foods they're meant to replace are far better. Stop letting big health food dump all over you and download the shit list today.
Fat is bad for you.
I just pop a pill and I'm fine.
Meat is murder.
It's time for bad food punishment. It's time for real nourishment. It's time for the Nutrition Heretic.
The following program is provided as information only and may not be construed as medical or health advice. It is not intended to diagnose, treat, or cure any disease. No action or inaction should be taken solely on the basis of the information provided here. Please consult with a licensed healthcare professional or doctor on any matter relating to your health and well-being. Aloha and welcome to the Nutrition Heretic podcast. This is Adrienne Hugh, the Nutrition Heretic. Today, I wanted to talk to you about my experience as a drug rep. Before I got into nutrition, actually, it was kind of straddling the time where I was learning about nutrition and just enrolling in school. I had to get a job that would pay the bills. And, of course, living in New Jersey, the only jobs there are pharmaceutical jobs. So, I took it really begrudgingly, but maybe this is just rationalizing it on my part. But one of the things, and in retrospect, I am glad that I did have the experience because it's firsthand experience versus kind of, hearing things through the grapevine. But I really learned what the pharmaceutical companies think about patients and about people and about the drugs that they sell. I had no shortage of trainers who told me that they don't care what the doctor's patients need. They need to be on this pain medication. And, kind of, how do we say this? Off the record, telling doctors that, you can push that upper limit. It doesn't, you don't have to stop at 400 milligrams. You can go to 12 or 1600 milligrams, and that's going to work fine for your patients. And it's perfectly safe because it, doesn't agitate the stomach or, cause any kind of homeostatic, processes to begin failing, because it's so safe. You can just prescribe. And really, it was incredibly disturbing to see that. On the flip side, I dealt with a lot of doctors who said, I don't have time to argue with my patients, because I was actually the rep who would tell the doctor, well, doc, did you see these side effects? Did you know that this could happen if you gave them the upper limit or, beyond the upper limit? And many of them were very interested and said, oh my gosh, I just had a rep in here today who didn't tell me all the stuff that you're telling me. Others were saying, well, you know what? I don't really care. I don't have time to argue with patients. They see the commercial on TV. They want this stuff. I just give it to them because I've got to make money. So, it kind of ran the gamut of the doctors who really cared to the doctors who just wanted the whatever kickback they were getting from the drug companies, or, commissions, free lunch, whatever it was that they were, expecting to get in return for prescribing. And, like I said, many of them, it was just the bottom line. I make more money the more people I can cycle through my office. Yes, very disturbing. In any case, that brings me to today's guest heretic. She is psychiatrist Anna Lembke and the author of Drug Dealer MD. Thank you so much for being on the show, Dr. Lembke.
Oh, thank you for having me.
Do you know what I'm talking about when I talk about these doctors who, either don't have time to be bothered or have just been misled about the safety of these drugs?
It's interesting for me to hear the perspective of a drug rep because, drug reps from a physician's perspective, they're always good looking. They're always very well dressed, and they come in and tell you all the glories of the medication that they're advertising. So it's interesting for me to hear your personal story of having been a drug rep and having been horrified by what your employer, the prescription drug maker, was trying to get you to do. And also, it sounds like you were pretty horrified by some of the physicians that you worked with.
Yeah.
I think one of the major thrusts of my book is that the current prescription opioid epidemic or prescription drug epidemic that we find ourselves in is certainly in part due to aggressive marketing by the pharmaceutical industry, as well as opportunistic physicians who just want to make a dime. But one of the main messages I really want to emphasize is that a lot of doctors who have been caught up in overprescribing of opioids are actually well-intentioned good docs who got caught in a system gone awry.
Right. Now, are they getting caught? Because one of the things I learned, sorry, before I go into that, most of the women that I worked with were all cheerleaders, by the way, in college and high school.
Yeah. You're all really gorgeous.
Like literally cheerleaders.
Life, but I imagine you are beautiful.
No. I was the one they threw in just to mix it up a little bit, add a little flavor to the group. But what I kind of see with the doctors is that, and this is what some of them actually told us, they were the doctors that were hired to train us at certain points, that would say things like they didn't know what to do until pharmaceutical drugs came along. Like, we knew what the disease was. We knew the etiology and the pathology of this disease. We just didn't know what to do about it. We could basically just diagnose, but we didn't really have anywhere to go. And my experience as a drug rep was that it was our job to educate the doctor. So, they didn't really have that kind of training within medical school, but they were relying on the drug companies to do all of that end of the training of how to treat various disease states and pain.
Oh dear, that's a scary thought. Because, the education that a pharmaceutical company will give is going to be all about the upsides and almost nothing about the downsides of a given drug. So I really hope that doctors are getting more of their education in medical school and residency and from reading the scientific literature than they are from drug reps. But you're absolutely right. There's no doubt that drug reps have a huge influence on doctor prescribing, in part because of the frankly biased information that most of them disseminate, with an emphasis on the upsides of their drug and not on the downsides, but also on the kinds of perks that drug reps historically bring to doctors, either in the form of small gifts or lunches, or even in larger forms like cruises or funding for their research, or payment for being on some kind of speakers bureau where they go around to talk to other doctors about the glories of a given medication.
Right. And those are some of the kind of people that we had as well, because they would train us and then they would talk to the doctors as well. It is something that I think the average person is not aware of how much is going on behind the scenes.
That's absolutely right. And that's really what I wanted to show in my book is what if you pull back that curtain on the medical profession, what does that look like? And it's easy to get cynical. And despite the title of my book being Drug Dealer MD, really my book is very I think is very pro-doctor and really tries to explain to people why even a well-intended physician could be prescribing in a way that harms their patient.
Right. And, this was something that I found really interesting in your book as well, because as a nutritionist, I also feel, I have to deal with a lot of people who say one thing but want another. They say they want to change their diet and they're ready to change their diet, but then as soon as you tell them what they need to do, it becomes a point of conflict. And well, I've been doing this all along and this is fun. No, it's not fun. You came here with a problem. That you got to make these changes. See, I think that traditionally, and when I say traditionally, I'm talking about 100 years ago, doctors would say, go home and eat these kinds of foods. These are the ones that will benefit your digestion, your pain, whatever. It's gotten to a point where, that's why there is something separate as a nutritionist. And there's the doctor who unfortunately has become synonymous, with dispensing drugs, dispensing the quick, easy way of getting relief, right? Or whatever resolution to your problem. So, when faced with that, to learn that doctors are going through the same kind of conflict with their patients as I do with clients, where, they come in and they're kind of dedicated, maybe because they saw the commercial or because, they are on disability, whatever their thing is that they want to continue. And they're just like, no, the pain medication, that's what I need. Nothing's going to work without the medication, without the surgery. And then the doctor isn't really trained, from what I understand you saying. And I feel like I wasn't adequately trained to deal with basically those personality quirks, let's call them.
Well, I think you're touching on what is really such a complicated problem to tease apart in medical care, which is that the physician, him or herself, is highly incentivized to prescribe pills and do procedures and get the patient in and out in 5 minutes, because our insurance company reimburses more for prescribing and for procedures than it does for educating patients or spending time with them. And at the same time, on the patient end of things, people kind of expect not just a quick fix, but also a miracle in a way. We don't have a culture that tolerates enduring pain. Mm-hmm. We have a culture that tells us that pain is dangerous and has no positive value in our lives, and that in experiencing pain, we actually set ourselves up for future pain through a kind of psychic process of creating a kind of a neurological scar. We also have a lot of cultural narratives that tell us that doctors can heal everything and that the body can't heal itself. Mm-hmm. And these are very profound differences from, let's say, 100 or 200 years ago, when doctors believed in the resilience and the healing power of the human body, and also believed that pain in and of itself was salutary, that pain boosted cardiovascular function and boosted immune function, and that to take all pain away was going to slow down the healing process. So we've really come a full 180 degrees in terms of how we conceptualize pain, both from a medical perspective as well as a cultural perspective. And that, combined with tremendous pressures on physicians to get patients in and out quickly, that all conspires to prescribing a drug, particularly when that drug has the immediate pain relieving effects of opioids.
Right. And I'm seeing a lot of parallels here with the previous episode that we did with JP Sears, who does those satirical videos about spirituality. And one of the questions I had asked him was about kids being coddled. And he said something very much parallel to what you're saying, which is that, when children are protected from any kind of discomfort, any kind of pain, any kind of disappointment, they don't get to flex their emotional immune system, as he called it. And so they become very dependent and codependent as adults because they haven't ever had to deal with things that happen in life. Is that what's happening with some of these people when they're getting addicted to drugs, that they're because they've never had to deal with pain? addicted to opioids, let's say. But they haven't had to deal with the pain, and because of what you're saying with the cultural values changing around that concept of enduring pain, that they see more of a reason why they don't have to deal with pain, why there's no benefit to the pain.
Well, I think the process, of opioid addiction there are certainly those cultural elements which contribute to it, but there's also a very profound physiologic change that occurs in the brain if opioids are taken every day, even if they're taken as prescribed by a doctor for a bona fide pain condition. And many people in this country live with severe and debilitating pain. So I would hate to suggest, that all forms of pain are somehow the product of an intolerance to pain.
Right.
There are people who have really awful, tragic, and very severe pain conditions, which greatly hinder their lives. And opioids work really well short term for pain. So they're very seductive in that sense, because especially for people who are suffering every day from pain, in the short term, the opioids help. The problem is that if you take an opioid every day, the brain adapts to the presence of that opioid such that it stops working and you need more and more to get the same effect. And when you don't have access to the drug, you go into a dysphoric or withdrawal state, which is incredibly painful, even more painful than the original pain condition. And this kind of what George Koob, a neuroscientist, calls dysphoria-driven relapse is what can really drive addiction and drug-seeking behavior.
Right. And what is, I guess, the first thing that comes to mind is that this, to me, sounds similar, if not exactly the same, as using street drugs, using alcohol to numb your pain, and the withdrawal people go through with those drugs. Is this somehow different? I mean, I know it's legal to do this, right? It's not considered damaging because of the way they've been marketed, perhaps, or less potential for addiction, let's say. The way that doctors are being told by the pharmaceutical companies. But is there any real difference between being addicted to a pharmaceutical drug versus being addicted to alcohol or cocaine?
There's really no difference. All addictive drugs work on the same reward pathway in the brain. And although each drug works in a slightly different way and has a slightly different withdrawal phenomenon, the natural history and development of addiction is the same across all different drugs, and including behavioral addictions like compulsive sex, compulsive shopping, compulsive eating. It all works on the same reward pathway, and the natural history is very similar, and it goes something like this. People begin with intermittent use, usually socially, recreationally. Over time, they increase their use to daily use. Over time, what used to work for them for whatever problem they were trying to solve or whatever high they were trying to reach, it stops working, so they need more and more to get the same effect. And then the continued use over long periods of time essentially resets the reward pathways in the brain such that even natural rewards are no longer rewarding. And when that individual doesn't have access to their drug, they go into a deeply painful withdrawal state, and then they need the drug just to feel normal.
Right. And I'm glad that you brought up the OCD behaviors, because that was one of the things that I was wondering is, when, and maybe we'll get to this more towards the end of the interview, but, when people have those OCD type behavior, they're coming off of the drugs, is there a tendency to move towards other things, hoarding or whatever kind of behaviors?
So we see this very commonly in the treatment of addiction, that an individual can get their primary addiction under control, but without ongoing recovery treatment, they often switch addictions to hopefully a more benign version.
Exactly.
But in a more, what we would consider, let's say, socially adaptive or optimal kind of addiction. But it does require, for most people, lifetime vigilance to make sure that the compulsive behaviors don't overtake them.
Right. So you're saying there are ways to channel them more positively, but it comes with continued, like you said, vigilance.
Yes. So, for example, I've had patients who were addicted to alcohol be able to give that up and then start running marathons.
Right.
And for them, that was a good and more adaptive substitute. But you can certainly imagine a scenario in which somebody would run compulsively and possibly end up injuring their bodies. In which case, that wouldn't be a good outcome.
Right. Right. Yeah, I have a friend who was in Alcoholics Anonymous, and he said the first thing he noticed when he went to the meeting is everybody was smoking. Because
Right. Yeah.
nobody was drinking, but they replaced it with something else.
Right. Well, there's an inherent hypocrisy in the way that we approach addictive drugs, and that probably the two addictive drugs that cause the greatest loss of life, not probably, but definitely the two addictive drugs that cause the greatest loss of life worldwide are alcohol and tobacco, which are legal in most countries. So that's a strange kind of paradox, because in truth, alcohol and tobacco really work in much the same fashion on the same reward pathways as heroin or cocaine.
Yeah, and what you were saying about the habitual use, and then we kind of segued into alcohol and smoking, is some of the older school doctors that I've been reading, because I love to look at my old stuff before like all the marketing got at everything, and I love to look at some of these older doctors, from the 20s, 30s, 40s, even up until about the 60s. They were writing some really provocative things, and one theme that comes up over and over again is the use of alcohol. Many of them will say, because right now there's and I think we're just turning everybody into a nation of alcoholics, to be honest. But we have, everybody saying, oh, you got to drink your red wine at 5, and it's good for you, and you got to have wine every day because that's what the French do, which is BS. Because I lived in France and not everybody drank wine every day. And as a matter of fact, I wrote a book called Frenching Your Food, which is about the way that the French just love their food. And everybody here thinks that we're being like the French because we drink wine. Very few of my thin French friends drink wine daily.
Interesting.
And one of the things that is mirrored in this old data, or these old books and texts that I'm reading, is that the occasional use of alcohol, even if you kind of overdo it, is better for you than the daily use of alcohol in small amounts. And the rationale that they all seem to agree on is that when let's say you just, binge drink, right? This like one weekend, it's, a wedding, whatever, and you just get sloshed. Their understanding is that the body understands how to mount a defense to that when it's occasional. But when it's every day, it starts to think that it needs that, and it becomes like it tries to incorporate it into the body's system. And so I just find, and I almost hear you saying something that echoes that.
Well, let me challenge your perspective just a little bit, because large epidemiologic studies have looked at who are the healthiest drinkers in the United States. And it turns out that if you look at all comers, those who drink no more than 1 to 2 standard drinks per week are the healthiest Americans. And the standard drink is 1 12-ounce bottle of beer, 1 5-ounce glass of wine, or 1 ounce of hard liquor. It turns out that those who drink in extreme moderation are healthier, obviously, than those who drink excessively.
Right.
But they're also healthier than those who drink not at all, which then raises the question, is alcohol in moderation actually physically healthy? And I think to that, we can say there's still some deal of controversy. There are these various, chemicals in red wine in particular that have been thought to slow aging. But if you look more closely at those data, what you find is that the probable reason that moderate drinkers have lower rates of morbidity and mortality than non-drinkers is because that non-drinking group includes what we call sick quitters. Who are sick quitters? Those are people who end up with cirrhosis or on the liver transplant list because they drank to such excess that they need a new liver. The other probable reason is that those who drink in moderation probably do a lot of things in moderation. They probably eat in moderation. They probably exercise in moderation. So, when my patients ask me, is red wine good for me? I say to them, there's no real evidence that red wine in and of itself has some kind of health benefits. But if you drink in moderation and do many other things in moderation, the data tell us that you will probably live longer and be healthier than people who use alcohol in greater amounts than the two drinks per week. And certainly the data also show that any adult male who has more than 14 drinks per week or adult female who has more than 7 drinks per week greatly increases his or her risk of all kinds of outcomes, from liver disease to pancreatitis to cancer to death.
Right. And then I think we're basically saying the same thing, because you're talking about, 1 to 2 drinks per week, which is pretty much what he's saying. He's saying, you can have, these doctors are saying, or, a lot, like I said, most of them are old school. Some of them are current and in France, actually. And they're saying that if you drink, because if you don't drink often, 1 or 2 drinks might be enough to get you, quote unquote wasted, right? But it's the 7 to 14 glasses of whatever it is throughout the week, even if you're just drinking a little bit every day, but then your body kind of starts to expect it. So, and he's saying that, but if you, drink once or twice a week, your body's not going to, your body knows that this is a foreign substance, and it exercises that immune system, basically.
Right. So anytime you ingest an addictive substance in a high enough quantity that it causes your set point or your baseline homeostasis to be altered, you've triggered a stress reaction. Mm-hmm. And in order to recover from that stress reaction, there has to be a reasonable period of abstention from that drug or alcohol in order to reset things. If you don't wait long enough between uses, then you basically set yourself up for a chronic stress reaction, and then that's what leads to the long-term adverse health outcomes.
Exactly. My husband, he likes his little, well, he doesn't do it every night though, but he likes his little whiskey at the end of the day. I'm like, watch
right.
it.
And so, I think the important message is moderation, and not some non-drinking days. But I guess what I would want to emphasize is that binge drinking is also very unhealthy.
Oh, yeah.
If you're having, more than 14 drinks in one day,
right,
then you're doing serious damage to your body.
Right. Yeah. When I say binge, I just mean, I didn't mean 14.
Your
but
version of a binge.
Yeah, exactly. That's the thing. It's like, and some people's version of moderation, actually, most people's version of moderation is usually not that moderate.
And of course, with my population, I treat people with addiction. So for many of my patients, moderation might be 1 6-pack of beer instead of 2.
Right. Exactly. That's a very good point. So where does poverty fit into all of this? Like, where, you mentioned how socioeconomic class may be one of the factors that end up playing quite a significant role.
Yes, so a lot has been said about the ways in which this current opioid epidemic has afflicted middle-class white populations, and in many discussions, that's been the source of much criticism that the U.S. Government, for example, is only paying attention to this problem now because it's afflicting white middle-class suburbia. But if you look closer, what you will see is that over the last 30 years, it is certainly true that the rate of opioid addiction and opioid overdose deaths has risen among middle-class white populations, but it has also risen among Black populations, and risen highest actually among Native American and Native Alaskan populations. So it's not really true to say that that it has only or primarily afflicted white middle class groups. It's probably fair to say that it's gotten so much attention because it's afflicted it afflicted that group. But the poor and people of color have definitely suffered during this opioid epidemic. And, we well know that socioeconomic variables contribute to the risk of addiction. There are many risks of addiction, including genetic risks, including co-occurring mental illness. But we also know that poverty and unemployment and homelessness and other social determinants of health contribute to the risk of addiction. And one of the scariest things possibly is that for the poor who have had health insurance in the last 3 decades, and who have gone to see their doctor, they may have been at even higher risk than the poor who didn't have health insurance and didn't go, because in the 1990s, if you had pain and you went to see your doctor, especially if you were poor, they were likely to prescribe opioids, because people who live in poor communities often don't have access to alternative pain treatments. For example, psychotherapy, physical therapy, acupuncture, massage,
Gotcha.
those types of things. So it's a very, it's certainly complicated. But one of the points that I make in my book is that, disability insurance has, in essence, become the modern social safety net. And disability is something that people can go on if they're unable to work due to a medical illness. But disability insurance, the value of income from disability insurance rose faster in the last 3 decades than wages for baseline entry jobs.
That's crazy, yeah.
Yeah, so disability became a very attractive way for people simply to earn a living. And one can understand that. But in order to justify disability, many individuals then have had to take potentially addictive medications prescribed by a doctor. And so we're set up for the development of addiction on many levels, having nothing to do necessarily with an underlying medical disorder.
Right. Yeah. That was a particularly interesting part of the book because I have known several people throughout the last, probably 10, 15 years who have some kind of pain, some kind of something left over from a surgery. And similar to what I was saying before, they've made up their minds that the only things that will help them are medication and surgery. So, they'll ask me things, they don't want to pay for it, right? But they can ask me questions about what's going on with their body. And that's when you know that they're not committed to really doing anything for themselves. But they'll say, oh, well, what's going on here? And then they'll say, no, but you don't understand. The tendon is tearing and there's nothing that's going to repair it. It's like, well, the food you eat is what causes it to repair, that's what holds it in place in the first place. But, they don't see that. And it becomes, and it's gotten, very tense. And then, one person came to me, I do, an energy medicine technique called EFT, which is tapping on meridians. It's very similar to acupressure. While you say, different things, and people actually, I could tell it was working because they got mad at me. They got really, really angry. And because it's the one thing that EFT is known for working well on is pain. I've had people who, I would, years ago, I was at a chiropractor and it was rainy and there was a woman there who had migraines and I helped, tap her through all the different points. And cause she said, she was like about to throw up, whatever. All of that went away. I saw her maybe 20 minutes later. She worked at the health food store. I saw her in the health food store and I said, how are you feeling? She goes, I actually was able to have lunch. And she said, normally I wouldn't be able to do that. So this is something that I wouldn't say it works 100% of the time, but it's pretty darn close, and so, but it was very interesting to go through that and see people, get very angry because they're like, well, I need my medication. Let's just stop now. I have to go get, fill my prescription. But then it was interesting because it did become part of their identity. Another thing that you touch on, it became their identity to be this person with this problem that prevented them from working, that prevented them from, skiing or whatever. And it really became the focus of their lives. And many of them never went back to work after that or ended up changing careers. And maybe this was, in some subconscious way, a way for them to get out of the job that they had that they didn't like anymore. But yeah, it's, without having read your book previously, it was, quite jarring to see how attached people became to that identity of the person with, the busted elbow or the bum knee or whatever it was.
Yes, it's very sad to see that. I have many patients over the years whose primary identity is that of being a patient. Often the most important people, if not the only people in their lives, are their doctors, the nurses, their caseworkers. They've often lost touch with family members. Maintaining that illness is not just crucial to their identity, but also crucial to their income. If they're on disability, if they were to get better, then they would lose that income. And perhaps most insidious of all, illness as identity, which has become so pervasive in our culture, fosters a victim narrative and victimhood as a right to be compensated. And in the context of a victim narrative, in my experience and in my opinion, people can't really get better. It's not an adaptive narrative because it's a narrative that requires them to remain ill and to always look outside themselves for somebody to heal them. And that's kind of, as I see that, whether your illness is addiction or whether it's chronic pain or whatever it is, it makes for very unhappy lives.
Right, exactly. It is very sad because I want to say, like, just off the top of my head, that each person that was in that situation, and couldn't do their work anymore and whatever, they had in the process driven everyone away from them in their lives,
right.
their families, their closest friends. Oh, they just don't understand me. Well, it was, right. it was really, I can imagine how isolating that becomes over time.
In my treatment of patients with addiction, when they first come to me and they're trapped in the cycle of their addiction and intoxication, drug seeking, withdrawal, they very often have a victim or a blaming narrative where all the problems in their lives are caused by other people, right. And they're not able to look at their own contribution. One of the most beautiful things about recovery for addiction, and one way I know that my patients are getting better, is that they begin to look at themselves and the ways in which they have contributed to their life problems, and they're no longer in that blaming stance, or at least not as much.
Right. Yeah. And it always boggles my mind because, just to refer to the internet, there's no shortage of inspirational videos of somebody, like the one guy, he's about 2 feet tall, doesn't even really, I think he's got like flippers for arms and like, feet, but no legs and, all of this stuff. And he's like, answering the phone on stage and giving people hugs and, like doing backflips. Yeah. And I'm thinking he can do it. What's your problem?
Yeah. He's inspiring. Yeah.
Right. So you see that and it's like, yeah, there's really no excuse, right?
Well, I think maybe a way to frame it is to just see it as part of the pathology of that individual, and to try to help move them toward building a different narrative, have right. them, slowly begin to reflect on, after empathizing with all the ways in which, they've been undone or harmed by others,
right.
begin to have them look at, well, what do you think you contributed? What are some of the character flaws you might have, because we all have character flaws. So
right.
what might be some of yours? And when patients can start to look at that, then that's really a sign of progress.
Right. Actually, that's a very good point. And because when I discussed people who got mad at me, one of the phrases that's often repeated in EFT, emotional freedom technique, is, even though I have, whatever the problem is, I deeply and completely love myself. I accept and forgive myself. And I think that forgiving myself, it's like, well, I didn't do anything. Why do I have to forgive myself, And I think that is actually one of the things that will set people off, because they're like, well, what about, or if they should forgive someone else for doing something to them, and sometimes I think that when it comes to forgiving ourselves, it's not necessarily that we did the last thing that caused the problem, but we trusted someone. I forgive myself for trusting that person for doing those things to me, or whatever they did, but they did what they knew how to do given the set of tools they were given, whether it was intentional or not, whether it was their bad attitude or something that they were really trying to do the right way and they up. That's just where they were in their journey. And unfortunately, you got in the way, you know? So, you know, there's a lot of that going on. So, I wanted to touch on what you call the professional patient. And, you know, one, what that is, and two, when did you discover, you know, the story about how you discovered that this was a serious problem?
The professional patient, as I've touched on a little bit today already, is that individual who completely identifies with being a patient as their core identity in the world, but also relies on their disability income to pay their bills. And those individuals are in a unique bind because they, in their patient role, go see doctors in order to get better or at least not get worse in their chronic illnesses. On the other hand, if they were to really make improvements, they might lose their disability payments. So it gets to be a catch-22. And often patients aren't fully conscious of the ways in which they are sort of perpetuating their own illness. And they also have to validate their status as a patient by taking medications. I cite instances in the book where patients don't qualify for disability unless they're taking certain types of powerful medications. So it's a phenomenon, again, whereby being a patient has become a way to pay the bills. The social safety net in this country for the poor, for the unemployed, for the undereducated, for the homeless is nearly non-existent. We eliminated welfare in the 1990s, and we largely replaced it with federally funded disability for medical problems. So, you know, when we're medicalizing poverty, what that means is that we're forcing individuals to be ill in order to secure an income. And when we make people show up in the healthcare system to pay the bills, they're likely to get harmed by the unnecessary health interventions or medical interventions that they receive, particularly if they get prescribed an addictive drug like an opioid.
Right. And when you first started noticing, like what was your revelation where you were just like, oh man, this like person, you do mention one story of someone who was basically going to several doctors to get drugs.
Right. Well, what I began seeing more and more of in my practice was patients coming in with multiple disorders for which there was no objective evidence. They were on up to 20 medications a day without any real reason for those medications. They were going to, 5 to 10 different types of doctors, each doctor taking care of a different body part. And over time, they were really becoming ill through the experience of being a patient. One patient I talk about in the book, Sally, she's in a wheelchair and she actually has diffuse muscle wasting and muscle atrophy from being in this wheelchair for more than 10 years. And she says that she's in the wheelchair because of multiple sclerosis, but there's no objective evidence that she has multiple sclerosis.
Right.
So it's a very tragic scenario where patients adopt the patient role for so many reasons, psychological reasons, financial reasons, and as a result, they end up sicker for it.
Right. Yeah. One thing that I've noticed as well, talking to people is, again, that there's that badge of honor. I'm sick, I've got this, but they can also when you said when you referred to professional patient, a lot of these people can talk better about their disease state than their own doctors.
Oh yeah, they're very knowledgeable, especially in this day and age with Google and the internet. Yeah, they know what they're talking about.
Right, and it's funny because it's almost like they think and I think it's those ads on TV where they started like renaming things like incontinence. They would urinary incontinence. They would start calling overactive bladder disorder. Just making up these catchphrases and cute little terms that people could identify with. But yeah, I see people, it's almost as if they think that they've gone through medical school when they start telling you about the pathology of the disease and how it can only be treated this way. And it's kind of an interesting.
Yeah, I mean, in some ways, I think in some ways, I'm actually for this freer dissemination of medical knowledge.
Yeah, for
and
sure.
I'm very happy that people can access sources like the internet and read about, illnesses and read about drugs and find out more and, really educate themselves.
Yeah.
The problem is that the internet is completely blind to the quality of information at different sites.
Exactly.
So it's very hard to have any kind of quality control around that. And I don't know what the solution for that is. In general, I think it's good for people to educate themselves as long as the sources that they're using are reputable, and that's hard to control.
Right, exactly. I know. I completely agree. I think it is good that people, can do that can do that research and can learn more about their bodies. I think what worries me is when. No, sort of like anything, you can use it for good or you can use it for evil, right? So some people use it to bolster their case as to why they can't get better.
Well,
because
I think
they'll just.
and perhaps,
I was just going to say that they'll just choose which sites they want to pay attention to and then ignore the rest.
Right. Well, and perhaps the phenomenon, you're observing, I know I have experienced this, is patients who come to see me who already seem to know what kind of treatment they need, and makes me wonder why they came to me in the first place if they already know. Do you know what I mean?
Oh,
because
yeah.
if they,
I think it's corroboration they're looking for personally, but yeah, no, you're absolutely right. I've seen that. So do you find that when there is this kind of professional patient, there is, this person who knows everything about their disease, they're committed to taking the drugs and they want the surgeries, even though, there's, like you said, with several cases, what you know about their health history doesn't really point to them needing most, if any, of the drugs that they're on. Does that somehow dilute or otherwise impact the legitimacy of treatment for people who do need it, people who are like in serious pain, people who are, is that becoming such a problem that the people who need it are not getting appropriate treatment?
I think you're probably right about that. That there are people out there who really do need opioids, for example, for their pain condition, and are now having a lot of difficulty getting those medications because of the many numbers of people who have become addicted to opioids through a doctor's prescription or otherwise. So I think you're right. So some of these phenomenon are probably contributing to poor quality care for individuals, even individuals who could benefit from some of these remedies.
Right. Yeah. Yeah. It's my parallel there is with celiac disease. People finally acknowledging that it exists, and then you've got regular gluten intolerance, and then you've got people who want to be part of the club. They they feel left out, and so they want gluten intolerance, and they want to say that they're gluten intolerant. And then you catch them eating a slice of bread when you're not looking, or when they think you're not looking, and then it just people go, well, this is just a fad. It's like, and that's becoming a problem for the people who seriously have the problem.
Mm-hmm. Yeah, you must in your work see a lot of people who use food and use nutritional diets or restrictions as sort of a way to gain identity or structure their lives.
For sure.
I mean, which isn't necessarily all bad, right? If it leads to healthier habits. Right,
but so often, and I talk about this a lot on the show, is that we've become a nation of eating disorders, and it's just pick and choose, right? My brother-in-law, he went to the doctor a couple of years ago, and the doctor got angry at him because he doesn't follow any specific diet. He just eats. And she was like, well, what diet do you follow? And he's like, I don't, I just, I got food around. I mean, I'm not saying that he eats that well, but, she was like, well, you have to choose something. And so she wanted him to be in a box of something. And one of the things that I've argued over the years is that because so few people still go to church or whatever temple, their families used to go to. So few people have the identity of religion, which, was often the kind of the center of everything. That's how a lot of people, until baptism or confirmation, let's say, became a thing. you were baptized at birth, and that's when you were written into the scrolls of your town that you were born, right? So that was a way of controlling who was in the knowing who was in the town. You were just immediately indoctrinated. We don't have any like core central faith anymore for most people, and I think that for food, I don't know if it would be the same with opioid drugs and being a professional patient, but with food for certain, a lot of people are using their vegan or paleo or whatever diet as their way of continuing the rest of their lives, and it's the system upon which they base all their decisions. And so I do think that there are some kind of core human, I don't know if I could call it needs, because even atheists, have become so belligerent and so proselytizing of their lack of religion that it's become a religion to be an atheist now.
Right.
So
food is an organizing principle in people's lives.
Exactly. So there's a lot of that, and one of the messages I try to say is like, okay, I personally, for what I've seen over the years, and many of our guests have agreed, particularly those coming out of the Chinese medicine field, because Chinese medicine is more about balance than just one hardcore thing. But, you follow exactly the same thing for 18 to 24 months, and your body's like, I need a change. The seasons have changed around me. We've had dryness and cooling and all these different elements outside, and you have not changed what you're eating. And that's when you start to see a lot of these diets start to fail, because initially people feel great. And then, after a while, they don't feel so great and they can't figure out why. They're like, I'm still doing the same thing. And it's like, well, yeah, your body ebbs and flows just like the rest of nature. And, it's a matter of paying attention to that. But enough about nutrition.
Well, it's interesting. So you're really advocating for a more holistic, kind of naturalistic, rhythmic approach.
Right.
I mean, it's eating, in high income societies with all the access to food and unhealthy food that we have. I mean, it is a challenge for all of us.
Oh, for sure.
So, how do people sort of meet that challenge? And it sounds like you're advocating for a sort of a moderate kind of approach to the whole thing, as opposed to one of these extremist diets.
Right, and I think that all of them, see, that's the thing, is that all of these diets have some foundation in truth, and they all have some value and some piece of the puzzle that they bring to the table that maybe we've overlooked. So macrobiotics. Would never recommend it for anyone, but they told us a lot about fermented foods that we had forgotten. There's the raw food movement. Yes, a certain amount of raw food is good. There's the paleo movement. Yes, we've been eating way too much grain, but that doesn't mean that you should follow any of those for the rest of your life. Therapeutically, I think they can all work beautifully. But for a long-term approach, I like to see, there's a reason why, apples come into season a certain time of year, or pineapples, or whatever it is. And I think there's a lot of wisdom in that kind of cyclical nature around us, and that we need to get a little bit more in tune with that. So anyway, let's get back to you. Sorry, I didn't mean to hijack your interview.
It's interesting. It's interesting for me. We don't learn much about nutrition in medical school.
Right. Actually,
I'm sure you know.
Yeah, unfortunately. and I'm sorry if I say anything against doctors.
No,
but actually,
I have a wonderful young resident now who is very interested in nutrition as a way to help people with their mental health problems, and she's a young MD. So I think that may be shifting.
Yes, and there are definitely some who have gotten it, and many of them have gotten it similar to how I have, which is just through your own, failures on the regular system. There's something else out there. And, for some of us, there is that, what we talked about before, that finality, like, oh, doctor didn't have something for me. Can't be fixed. Sorry. I'm just it sucks to be me. And this is the life I'm going to lead. And then there's people like me who are going, well, heck, my ancestors never had this problem. And my mom says that my mom was a registered nurse. So she knew a lot about all of this stuff. She saw the differences in how things were handled. And many of my aunts are also nurses, and they tell me about, just the differences between when they first started working and where things ended up when they retired. And they're like, this is ridiculous. That, like my one aunt, she worked in the NICU at Albert Einstein Hospital. She said when she first started, like maybe 40 years prior there, that it was very rare to see a baby come in at, like you say, 30 weeks. Like they saw maybe a few a year that would come in at, after 30 weeks of gestation. She said by the time she left, most of the children they were seeing were 20 weeks gestation. Or somewhere in that 20-week period. So, she's just seeing those changes. And then and if you look at the parallels and how different we've been eating in that time, like what's, even the stuff that we think is our time-tested, family recipes, all the ingredients have changed,
Right.
They're all GMO'd and low fat and high fructose corn syrup and, and aspartame and all this other crazy stuff.
Yeah.
So actually, what you were starting to say about this young doctor is what I was kind of leads to the next question I had for you, which is that we had someone on the show previously named Julia Ross, and she also deals with people with addictions, depression, anxiety, etc. And she uses amino acid therapy because she sees the, like you talk about the dopamine, for example, and, just the different neurotransmitters. She sees that replacing the amino acids that trigger those responses or those neurochemicals are very helpful. Do you get into that end of therapy, or is it mostly about the narrative?
Yeah, I don't know much about that. I've heard of patients taking those types of monoamine precursors. I think they're mostly over the counter.
Yeah, many of them are.
You don't need a prescription, but
Right.
I really don't know much about that world at all. The bulk of my practice really has become treating patients with addiction and co-occurring psychiatric disorders, and also deprescribing. And deprescribing is kind of a newly coined term to refer to getting people off of the many psychotropic and pain medications they've had started by other doctors.
Okay. And then, so what's I guess to give people like an idea, like a little flavor of the process, obviously I'm not expecting you to give away the farm, but, when someone comes to you with an addiction, is it confronting the addiction? Is it more, meeting them where they are? Well, I guess no matter what, you have to meet them where they are, but you know what I'm saying? Like how are you opening up that narrative with them and holding their hand, so to speak, to get through to where ultimately I think you both want them to be?
I start by just listening to their story. Addiction narratives are each as unique as human beings, but also have surprising numbers of similarities. And then we talk about, where they are, what they're willing to try next. Treatment is a combination typically of some kind of psychological or psychosocial intervention, maybe individual or group therapy, maybe going to a mutual help group, and also often some type of medication to help them stop using the addictive drug that they're addicted to. So that's pretty typical. For the kinds of interventions. I treat patients in an outpatient setting.
Okay.
Sometimes that's not enough for them and they need to have a more intensive level of treatment, and then I refer them elsewhere. I'm also getting increasing numbers of patients referred to me who have become addicted or dependent on prescription drugs like Valium or Vicodin, the opioids that we've talked about. And then I help those patients get off of those medications. And that's a very labor-intensive process. It can take a long time. It's very painful for patients. So that requires often months to years to do that work. Yeah, so that's what I do.
Wow, that's God bless you. I don't have the patience. I'm like the people who want the pain really fast. Right. But seriously, I mean, it's that's what people have to realize, that, usually if you have an addiction, I'm going to jump out, just come out and say, I'm thinking it didn't happen overnight, and recovery is likely not going to be overnight either.
That's right.
So
it takes a long time.
So as a society, where do we go from here? Like how can we as a society kind of prevent falling into this slippery slope of addiction and, addiction to prescription painkillers?
Right. Well, I think, on the prevention side of things, we need to get in earlier than ever in terms of adolescence is the time that most people begin using addictive substances, and 90% of people who develop addiction later in life began using in adolescence. So that's really an important time. What we've discovered, however, is that going into the schools, for example, and educating students about the dangers of addictive drugs doesn't work. What does work is providing them with alternative rewards or alternative sources of dopamine neurotransmitter, which is your neurotransmitter that's typically released when using addictive drugs. So we need to provide kids with interesting, challenging things to do instead of using drugs, and that's a tall order, but that's certainly really necessary. So many teenagers today are just simply bored. They don't have anything to do.
Tell me about it. But I give my kids stuff to do and she doesn't want to do it. I'm like, but you're going to get bored, Come on now. Yeah. But yeah, you're right. Because in school, they even had here, they like bust a bunch of kids down to, you don't even know where I am, but they bust them like an hour away to this big rally. It was like all the schools from this side of the island got together and they were all, they had speakers and music and all this kind of stuff and teaching kids about drugs or whatever. And as far as I know, my kid doesn't take drugs. There's sometimes, parents don't know.
Yeah,
but yeah, I wonder to myself, is that enough? And like you said, it's kind of that, the old saying, idle hands are the devil's workshop, right? Because they have nothing to do. So yeah, that's been like a challenge with us, so what do you want to do? Piano, we bought you one, or guitar, what are some of the things that you think, is it those kind of extracurricular activities, robotics and basketball, whatever, that type of thing, or is it something else?
I think for adolescents, one of the most important activities that they can engage in is daily exercise. If either in the context of a group sport or some individual endeavor, but moving their bodies, reconnecting with their bodies, and engaging in some sort of challenging physical exertion is absolutely fundamental to decreasing the risk of addiction. The other important tools that we need to teach our adolescents are how to regulate their emotions. So giving them the language and the tools, whatever those tools may be, meditation, prayer, mindfulness techniques, whatever your particular family or community espouses, so that when they deal with the incredible surges and ups and downs of emotions in adolescence, they can begin to learn how to manage those emotions. So I think those are the really important. And then of course, community, being tied to a community, feeling that you're part of a family and part of a community and you have an important place there. We know that's very protective. We know that people who are actively involved in religious organizations have lower risks of developing addiction. So, that can be very helpful. So on the prevention side, that's the type of thing. The other thing I think on the treatment side is to better educate doctors about how to identify and treat addiction and do that from the first day of medical school. Right now, medical school education is impoverished by the lack of training in detecting and treating addictive disorders. So that's a really important piece. We also need to build an infrastructure within the House of Medicine to treat addiction and get insurance companies to pay for that treatment. And on a much larger scale, in terms of at the societal level, I think we need to carefully consider that medicine has become the de facto social safety net. And if we're really going to ask doctors to take care of not just diabetes, hypertension, obesity, and chronic pain, but also unemployment, homelessness, multi-generational trauma, then we have to make sure that we give the doctors the tools to address those issues, because otherwise they're going to be left shoehorning what are really psychological and socioeconomic issues into the very small kind of circumscribed definition of a medical illness, and that's not going to help anyone. If we decide that we don't think that medicine should be our social safety net, then I think we have to bring back a different social safety net to address these problems. And then I would say finally, in terms of the way that medical care is organized and doctors are incentivized to get patients in and out, to prescribe pills, to do procedures, we really need to bring back the primacy of the doctor-patient relationship. And to pay doctors and other healthcare providers for actually spending time with patients and talking to patients, and not just reimburse them for prescribing pills or doing procedures.
Right. Well, that's a pretty tall order, because we know that insurance companies are not they're not
right.
big on that. And yeah, that's a whole other thing to get involved with. But yeah, once you get wrapped up in that, and on the patient side too, well, my insurance would only pay for this, so this is what I'm going to do.
That's right.
I see that all the time. Oh, do you take insurance? Sorry, I can't, because I spent time with you.
Right.
Yeah. And that's not what the insurance company wants.
Right.
And my kids got to eat too. So, do you do any training of doctors yourself at this point, or otherwise, are you speaking to doctors at conferences and making them aware of this and letting them know that they're not alone in experiencing these patients coming through their door, and this kind of, maybe it's even a self-doubt about how to deal with patients, who come in just drug seeking?
So I would say that more than 50% of my professional time in the last 5 to 10 years has been dedicated toward educating other physicians, all stages in their career, in this area, because I feel very strongly that we need to prevent the harm being done to patients because of our own ignorance about these issues. I'm glad to say that my book has been surprisingly well received among the medical community, despite a title, Drug Dealer MD, especially among younger doctors. I've been very honored recently to be invited by the Johns Hopkins University Bayview internal medicine residents as their annual visiting professor and give grand rounds there. And so that was a great honor for me. I get asked to do a lot of medical talks, but to be invited by this young group of residents who read my book and believe in my vision is really encouraging, that, this younger generation of physicians is not going to make the mistakes that my generation made.
Right. Yeah. And it's really unfortunate, because I guess as someone who's self-employed, people think like, oh, a doctor, he can just decide whatever, and, he knows everything. But, what we don't know is the stuff going on behind the scenes, and not only the drug companies, but just the way that your hands are tied.
That's right.
There are, I do my share of doctor bashing, but that's based on the doctors who have kind of me in the past. But
We've all been there.
Again, another can of worms. But there are, there are many good doctors out there, and I'm finding that, the answer is often somewhere in the middle. But, a lot of these old time guys, like, people think, oh, well, they're, he's older, he doesn't know what to do. Like, I've actually had some of these people I told you about with the pain problems. Well, he's an old guy. He told me to go home and, rest it and put ice on it. I don't need ice. I need drugs,
Mm-hmm,
So, but, some of the guys in between, kind of lost that vision. Maybe they got into medicine for the wrong reason. Some of these guys, as there are people like you who genuinely want to help people, but there are some who, I've had them tell me, well, what am I going to do? The insurance won't pay for it. I got to make money. So, there are some that are, I guess they think they're killing two birds with one stone. I'm going to help people and I'm going to make a lot of money. And then they get in and find out that the helping part wasn't as obvious.
Robust.
Right. Robust. I like that word, robust, as they had, that module kind of got skipped over.
Right. It was a marriage of convenience.
Right. And
didn't
so
work out in the end.
Right. And then at the end, like, all they had left to look forward to was, the yacht or whatever they thought they were going to buy with the money.
Or maybe even the lawsuit at this point.
Well, that's talk about a can of worms. Yeah. I was horrified to find out what doctors pay. I want to, there were several doctors because I used to do, my drug repping was done over the internet. And so I would talk to like 20 doctors a night, at this job. And, sometimes I didn't really have much to tell them because I was the only one who talked about the side effects of the drugs because I wanted to make sure that they knew what was going on. And they would always say to me, well, that was part of how I felt good about getting a paycheck was that I said, you know what, if I'm going to be here, I'm supposed to talk about anything about the drug. Well, I'm going to tell them about the side effects because nobody else does. And then I'd ask them and they would say, oh, somebody came in today and they didn't tell me about that. Or I had a patient asking me for this and I wasn't sure I should give it to her. And now I know why, so I do feel like I did some good in that position, trying to let them know. But yeah, several doctors, sometimes we would just, cause we'd have to spend, you'd say, 5 to 10 minutes on the line. And so I would just talk to them about their practice and they would say like, oh yeah, I just paid my insurance. How much? And they're talking like 6 figures for insurance for the year. I'm going, what? Are you crazy?
Oh yeah, no, it's, one of the saddest things that I have seen more and more of is patients started in particular on benzodiazepines like Xanax and Valium, who were, at least by their report, and I believe it, never told by the doctor that these medications were potentially addictive or habit forming. And I think there are quite a few doctors out there who may not even know that medications like Valium and Xanax are addictive. So I think it's really important to know what the side effects are and to make sure that patients have informed consent, including for the risk of addiction when starting a medication.
Right. And actually you that was actually one of the questions I had meant to ask at the beginning, was that you talk also in the book about the quality of care being measured. And we had to do this as reps, on a scale of 1 to 10, what's your pain? That whole pain scale. So the doctors now being judged based on how much pain their patient is in, as opposed to whether or not the patient got better,
Right.
So,
yeah, and those kinds of pain scales have not been shown to improve pain outcomes. The only thing they've been correlated with is more opioid prescribing, which we know is most of what got us into this opioid epidemic in the first place. The other danger of those pain scales is that for people with chronic pain, one of the worst things you can do is to get them to focus intently on their pain. The real task at hand for chronic pain patients is learning to distract themselves from the pain. So if we're constantly asking them to rate their pain on a scale from 1 to 10, we're not really doing them any favors.
Right. You're validating it, if nothing else.
Well, you're encouraging those neural circuits that are already hyperstimulated.
Yes, absolutely. There was a quote that you had in here that I thought was so perfect, and it, has so many parallels to what I was even saying about food and cults and religion. Very similar. You say, in a world in which the struggle for basic survival, food, clothing, shelter, has become largely irrelevant for most Americans, the ill person is among the last of the great warriors. And that sentence really, for me, just really hit home kind of the underlying, maybe not but one of the probably strongest cases as to why this has become so pervasive and so widespread. And, people who, maybe, I don't know, would they have been addicted to street drugs if they didn't have these outs? But it's almost like a legalizing way of saying like, it's okay, you can just keep taking more because you're in this special category.
That's right. And I think we're all desperate for heroes. And really, there are no ways to be a hero in modern culture anymore. But one of the few ways remaining is the diseased person or the ill person who, through no fault of their own, is struggling against, mightily struggling against an illness. So this is a very attractive societal role. And certainly, if you had to choose between being an ill person and being a homeless, unemployed person, it goes without saying that you would choose the illness identity. And when the illness identity is that incentivized and then needs to be validated through the use of potentially addictive prescription drugs, it's no wonder we find ourselves in this current epidemic.
Well, I mean, we love the underdog, don't we? We like to see Clark Kent get beat up and then turn into Superman. We like to, we like to see these kind of
triumph over adversity.
Exactly. This is like our culture has been very much framed around rooting for the person who seemed to be the least likely hero, right? So yeah, it just kind of perpetuates all of that. Well, thank you so much, Anna, for being with us today. And you don't have a website, but you do have your book, which is Drug Dealer MD. You can find it on Amazon.com. We'll have links to it on our website. And Anna, if you have anything to share with us, please come back and see us again.
Great. Thank you so much for having me.
Thanks a bunch. Aloha.
The Nutrition Heretic Podcast is a production of Savor the Journey, LLC. Our audio editor is Nicola Popovich. Our podcast manager is Crystal McLean, and our operations manager is Michelle Med. I'm your host, Adrian Hugh, the Nutrition Heretic. You can find us at the new and improved nutritionheretic.com, where you can download the Nutrition Heretic's free shit list of 7 health foods to avoid like the plague. You can also listen to previous episodes at nutritionheretic.com/podcast. Be sure to like us on social media for updates. Our Facebook page is facebook.com/nutritionheretic and on Twitter @NutriHeretic. Contact us with show ideas, questions, or if you want to be a guest. And don't forget to rate our podcast on iTunes and Stitcher.